Hello everyone and welcome to this evening's Facebook Live. I'm Claire Morris, Clinical Manager at Wound Care People. Just to remind you, we're broadcasting live from our homes, so if we do have any problems, do please bear with us. Tonight's session is Continence Assessment in the Current Climate, and our speaker this evening is Sharon Eustace, who is Consultant Nurse, Bladder and Bowel Specialist Service in Cornwall Partnership NHS Foundation Trust. A big thank you to Essity for their support this evening, and also just to let you know, certificates will be available at the end of the presentation. You can send in any questions by commenting on the video. So without further ado, I shall hand over to Sharon. Thank you.
Thank you, Claire. It's really good to see everyone tonight and to be with you. And thank you to Essity for inviting me to join you on this Facebook Live. So as Claire said, I am a consultant nurse. I work for the Bladder and Bowel Specialist Service for Cornwall Foundation Trust, covering Cornwall and the Isles of Scilly. And I have an excellent team of clinical nurse specialists, and we cover children, young people and adults. And so essentially, I see my potential caseload as anyone from the population. So this presentation that I'm going to go through with you this evening isn't exhaustive. So there will be many influencing factors that impact on where we are today and how we're trying to survive through this situation. But I want to pick up some of the salient points that may be helpful for us. And of course, we're learning from each other all the time. So in terms of learning outcomes, what I think is really important is to understand what is, in inverted commas, gold standard continence assessment. Now, many of you will have this really sort of robust within your clinical work, but it's always very helpful just to remind ourselves. It's important to understand the challenges and positive outcomes of undertaking a continence assessment in the current climate. We have to do it differently. Not easy. But it doesn't stop us striving for the best care. And also understanding the learning outcomes from examples in practice. And I'm going to share two with you, one from a colleague in Newcastle and one from myself in Cornwall. So let's start with understanding the national picture. So continence assessment in the current climate. Before we got to where we are today, the national picture for continence or bladder and bowel dysfunction is huge. 14 million people, men, women and children of the UK have a bladder problem. And you can see from this slide, there is a significant issue going on. And this information is sourced from the NHS England Excellence in Continence Care document 2018. And you'll be able to find this on the all-party parliamentary group for bladder and bowel continence care, which is a really useful repository to be able to find some of this information. So moving on, we can see that as well as dealing with the number of people with a problem, we get emergency admissions, urinary tract infection. We know they're one of the most common healthcare associated infections. And of course, they can be associated with urethral catheters. So we're always striving to reduce the use of catheters because we know they're a hazard. And so it's really important that we're vigilant for that. And of course, the catheters can lead to catheter-associated urinary tract infections. And these figures are quite staggering. And yet sometimes it can be low profile. I know there's many colleagues across the country, nationally, locally, regionally, who are really doing some excellent work. And so we can't take our eye off the ball. So it's really important now, more than anything, that we can't take our eye off the ball in helping our patients and to reduce harm and to improve quality of life. But continence, as in incontinence and bladder and bowel dysfunction, affects quality of life across the age spectrum, from children, young people, to adults, to the elder and the frail. The loss of independence, psychological effects, and of course the physiological effects of infections, etc. There was only a recent study that came out from Brazil in November that shows that women with urinary incontinence can experience anxiety, depression, and stress. So therefore, we need to be mindful in our clinics, well, not face-to-face clinics at the moment, but necessarily telephone clinics, to ensure that we are picking up those cues and signposting people to cognitive support or talking therapies as needed. So what are the positives in the current climate and quality of life? Well, virtual initial contact can be a barrier to embarrassment. So it might be one of the positives is around having that consultation over the telephone or by video. It might actually help people to share more detail. I was speaking to a young person recently, and this is telephone contact. And certainly, I felt I got more out of him because he didn't have to look at me, he didn't have to see me, and so he was able to actually share some of his concerns about bedwetting. It may break down social barriers and social isolation, and we know there are positive and better ways of working identified. So I believe we are working smarter, but that still doesn't come without its challenges. It might be that patients present because now they can't obtain products as easily as they did. So maybe it's now, well, I will go and seek help. I will try and get some support from my GP, my practice nurse, my pharmacist, and get myself referred. However, there is an effect on the team. So I don't think we can ignore the impact on all of us of working in the current situation. Redeployment has been experienced by many of our colleagues, as has shielding and also social isolation. And so with the remaining team, it can be overwhelmed with workload and it can be isolating. So therefore, self-care and being able to look after each other is really important. I work with Cornwall Foundation Trust, and one of their slogans at the moment, which I think is really, really pertinent through staff wellbeing, is it's okay not to be okay. And I think if we recognise that, that's good, but we need to seek that support. If we seek support to look after us and our team members, then we can help our patients even better. Some positives here that it might be that we can spend more quality time with children, young people and adults through the way that we're working now. In some cases, children, for example, can actually improve. I was working with a family recently whose child was soiling and constipated before the first lockdown. During the lockdown, the parent was able to really knuckle down and encourage the correct behaviors of toileting, and the child became no longer constipated and soiling stopped. So that was a great success, and that was because the parents could put in consistency and remain kept the behaviors, the right behaviors and supportive behaviors going. So that really worked well for that particular family. Conversely, it can happen the other way. So some children actually can get worse. So working in partnership with industry is another factor that we can benefit by. And certainly my experience with working, for example, with Essity over these last few weeks has been really, really helpful. And the case study that I discussed will help to illuminate that. The service risks and issues experienced during this time is around the quality of assessments. And I think we have to bear in mind what we can achieve from face-to-face clinics. I know from the face-to-face clinics I do and that you do, you're probably watching, how your patient walks, what are the signs, what are the cues you're picking up to be able to help be an adjunct to your clinical assessment. Of course, we miss that on our telephone and some of our video conferences. So it's really important that we bear that in mind. So we have to be really vigilant for the signs of domestic abuse or safeguarding issues, because we're missing some of those cues that we benefit from when we see patients face to face. Even going into the waiting room and calling them to come into us actually gives us some information before they sit down and we build that rapport. Incomplete assessments can be a risk. I know some of my patients haven't completed their bladder diary or their bowel diary. And so that's something we have to work with. Despite us encouraging that, we've now suggested to our patients that they complete but keep it with them. So they don't necessarily send it back to us or email it back to us. So they keep it for the telephone consultation, and then we can work through it with them. So, and sometimes that, as we know, that can be excellent in terms of self-learning and self-management of their problems. In the first lockdown, We have developed a backlog, certainly locally. We developed a backlog. I could not do my urodynamic investigations anymore. So of course, all those patients I would have seen, I'm now trying to work through. So of course, our referral to treatment time is challenged, and how to recover that is really hard work. And so what we've got to have is really good communication and identify these recovery plans and how we can get back on track. And if we can't, how can we do it differently so that we can still deliver quality of care? And of course, the additional costs, maybe some people are shifting to buying products over the counter. It might be that they're not presenting to primary or secondary primary or community care. I know some of my community nurse colleagues have looked at prioritizing their caseloads when they started the first lockdown. And so some of those routine clinical assessments might have been pushed back because the other more priority cases have come forth. So therefore they may have stayed on products longer, or we actually commenced product. And of course, some shortage of administration staff may be a feature. Of course, it's a common feature for us without COVID. So this is an opportunity to work smarter. And I think, well, I know my team has started to work smarter. We're working from home. I didn't think I'd adjust to it, but I am. But I have the benefit of going in to see my patients still for my urodynamic investigations. And I find that really, really helpful. So I do get that balance. I can naturally adjust to working from home, but I know some people find that challenging because they need to bounce off team members to be able to get that rapport and to be able to get that, that inspiration. And so we have all different ways and different styles. So it's important that we find out what our style is and work to the best of our ability. One thing I've noticed is that when I'm working with patients face to face, and I know my colleagues, some colleagues have told me this as well, when we're working in masks or face shields, it really does make a difference to our communication. And I find that really challenging. I find that a very challenging situation personally, where a patient can't see my face, I can't see them, and you're trying to communicate everything through your eyes. And I like holding eye contact, so it can be quite difficult. So we have to adjust to that, but we still have to demonstrate that compassion for our patients, which I know we do. But of course, the mask does go to show how much we rely on body language and facial cues. So telephone assessments, they're good, they're helpful, but I think we've got to be mindful of doing them well so that we still get the components of a good clinical assessment. We have stopped clinics, and I expect many of you have. We're working out how to get back to our face-to-face clinics, and we're thinking about how can we do it differently. We don't want to lose some of the excellent approaches we've embedded now. We don't want to go back to where we were before. We think that we can pick up some of the best of what we're doing now and take it forth. And it gives us an opportunity to adjust, but bearing in mind how we look after ourselves and also predominantly our patients. Meetings held virtually, I find that really helpful. I'm not in my car driving from A to B all the time. But of course, in meetings, you lose some of the richness and the spontaneity of being together. So we have to bear that in mind. And I think I like to see my team often, and maybe I don't see them often enough. That's virtually, that is. So I think, there's some good learning all the time. So if we look at the a clinical story regarding telephone assessments, sometimes, and I noticed this for me during the first lockdown, is that when I was speaking to someone who was shielding and may not have seen many people, except someone who dropped their shopping off, is that, are they doing okay? Is there anything I need to be aware of? Are they feeling lonely, etc.? So sometimes there was more this general welfare assessment, which was really important to check and to make sure that I didn't need to involve other people of the multidisciplinary team or social care to make sure these people are safe and not struggling too much with loneliness, etc. So new ways of working are really important, whereas I believe we can be smart, but we have to be mindful of how we deliver telephone clinics or virtual meetings, virtual clinics rather. The Royal College of Nursing, I really advise you to get yourself signposted to this document. It's a guidance that came out this year. It really is a very useful opportunity to be able to check all the facets and elements of doing telephone consultations as well as we can. In terms of chaperoning, etc. So we shouldn't forget chaperoning just because we're not seeing people. So we've got to be very, very vigilant. And also, if someone has cognitive impairment and can't give consent, then how is it best to deliver that type of consultation? So it isn't easy, and I think it's an individual case by case, and the triaging of our referrals is really important to make sure we get it right. It might be that you start a telephone consultation and it turns out it's not appropriate to continue because you can't get the best out of it. I know one of my colleagues spoke to someone and they had really great difficulty hearing her. So all of these things will throw themselves up to be a challenge, and how we overcome that, we need to develop those skills in problem solving. The support from industry over the last few weeks, I have noticed, has been very, very useful. So, for example, virtual support from profiling, guidance and pathways. The advantages of working this way is meant actually, as we've seen quoted often, is that the NHS has speeded up how we can improve what we tried to improve for many years. So we are really galloping forward in using the technology that we probably haven't really been comfortable to use. So I think it can improve our productivity, flexible working, and as I said, some of these new ways of working will hopefully continue. There was this document that came out by Carers UK recently, well, last month, and it's very sobering, the impact of COVID-19 on patients and their carers. And I think we have to realise the wealth and breadth of work that carers do, that health and social care rely on. But the effect of COVID doesn't mean to say that there were no challenges beforehand. If we look at the Health Watch 2019, there's a very interesting document, and they looked at the challenges of people accessing content services. And when I read that, it's like, I'm sure we can do better here. People on waiting lists to get products, communication between patients, carers, and the healthcare professionals were not optimized. Physical needs not necessarily being highlighted in mental health care, or vice versa. In mental health care, the physical needs not acknowledged, or in physical care, the mental health needs not acknowledged. So it's really important, as we have said for many years, that holistic approach. Of course, some of the issues that can relate to carers are when they are caring for a loved one with dementia. And of course, if visiting is not allowed, those social stimulations are lost, and continence then can deteriorate. And of course, when we talk about children, some of you will know about the Ofsted report that came out this month that has shown from the first lockdown that children have regressed back into nappies, and that's really concerning. So, and there are maybe influencing factors for that, and what Ofsted came up with was perhaps that parents aren't able to work flexibly as much as they did. So in other words, toilet training and the resilience within families to maintain content skill for their children has been regressed, and some have ended back up in nappies. And of course, the Ofsted report talks about other factors for children where they have not benefited from that lockdown. So if we look at continence assessment, of course, this is going to be a reminder for many of us. And the purpose, as we know, is a robust clinical assessment to understand the symptoms of the urinary and fecal systems. So it's really important. However, to do that, to get that really good clinical assessment, we need to have that understanding of different types of continence problems. So our own education and training is still critical. Even though we're all jostling for how we work through this pandemic, we still got to keep our learning up to date. So it's really important. And it talks here about the gold standard and this is the NICE 2019 that was updated last year. And it's a really excellent document. And this is for women, but we have to consider all the other NICE documents that exists for children, young people, and also men. And I think if we go forward to look at this slide, and it takes a quote out about this from the NHS England Excellence in Continence Care 2018, that early assessment is really important. Early assessment and early identification of symptoms by a trained professional that is patient-centered and cost-effective. But only after assessment, and as we've all got to know over the years, is only then that we should consider treatment opportunities after clinical assessment and not move to management unless treatment is not appropriate or has not worked. And so containment products, for example, would be further down the line. But medications, medications would be within that treatment parameter. And so the level of interventions can be triaged and escalated, and making sure that we refer. I don't think we should stop referring. We know that there may be a backlog in other services around us, but that shouldn't stop us referring. We can't let people languish. We must get them moved through if it's clinically appropriate. History taking, we know history taking is vital. We can probably get a lot of what's going on from the history. So that's the medical, surgical, neurological, obstetric, mental health, and social, including all the things that we mentioned on this slide. For continence assessment information, I can signpost you again to the all-party and parliamentary group for bladder and bowel continence care, because on there is the new Coley model. Some of you will remember from many years ago the work developed by Wendy Coley, and now she has, with some team members and people around her, she's actually develop that and enhance that, and that's an online tool that's now available and will help signpost people through the clinical assessment journey. And I think that's a really wonderful tool to help clinicians and frontline clinicians as well. Physical examination, of course, this is a challenge for us. Really important when we're face to face, but of course some of this may have to be put on hold. Do this essentially when we're in this situation, but it doesn't stop us asking the questions to be able to see if we can have a verbal dialogue on these particular aspects. Of course, this will be missing from a lot of our consultations. Bladder and bowel charts or diaries, I like to call them diaries, really important. Some of my patients haven't completed those, but when they do, it's really vital gold dust information. And of course, we can get information on fluid and food intake. Talks about urine testing, but you know, we have to be mindful that we're not necessarily going to urine test on people over 65. There is guidance now on the asymptomatic bacteria. We're becoming much more knowledgeable on where we do want a dipstick and where we don't. So we have to be very cautious and make sure that we're using dipsticking wisely. Post-void residual urine, that's a challenge, isn't it? When I think, well, this patient would be ideal to do a bladder scan, but it might be that we don't have that facility to bring them in to clinic at the moment. It might be that I'll refer them for a kidney and ureter bladder scan. So some of these things, it's not at our fingertips to be able to do at the moment. And quality of life assessment. We do this with all of our patients through a self-assessment approach. We use the incontinence impact questionnaire, and we also use the ICIQ urinary incontinence short form. So we like our patients to complete those, and it gives us a really good, quick insight into the impact of their symptoms. If we pick up a case study now, and I want to thank Alison Laws for sharing this with us and allowing me on her behalf to present this. Alison has also written up her case study, and it's available through the journal Community Nursing. And this is focusing on women with stress urinary incontinence. Alison mentions quite rightly that several women, well, many percentage of women, up to 50%, will have symptoms. It's a common etiological problem that can happen in women. And of course, we hope that many women will present so that we can actually enable them to get it resolved. And of course, evidence does tell us that pelvic floor muscle exercises is a gold standard in being able to provide the treatment. NICE 2019, as I mentioned before, tells us that face-to-face assessment for vaginal examination of the pelvic floor is essential. And I totally agree with that. But of course, how can we deliver that in this current situation? So what Alison has done is try to find an alternative way to be able to continue good care, but actually adapt to this particular current situation. So she has done with her team comprehensive assessments over the telephone, fluid intake and bladder charts, and patients have emailed them back or transcribed them. And she's asked with her team specific questions to stress urinary incontinence. So that's part of our history taking. We have this global generic history taking, but then we want to focus down on specific questions related to bladder and bowel health, so we can actually understand what type of working diagnosis could we come up with. So in Alison's team, they looked at a consented guided perineal self-assessment approach using a mirror, using what's called the Mean Pelvic Floor Educator, which will be, you can see that on our website, and some of you may be using that already. In terms of intimate assessment, the General Medical Council have a very useful document that's available for you to see, and actually there's a link to it in the RCN guidance on remote consultations that I alluded to earlier on. In Alison's case, if required, they did a home visit following all personal protective equipment guidelines. Understandably, Alison used the tried and tested Haslam and Laycock approach in terms of the perfect, which is the power, endurance, repetition, fast, every contraction timed, and relax. So it's been tried and tested, and it's now the acronym is embedded within our work. And so Alison's team attempted to teach intervention to enable patients to start the treatment, and they used this educator vaginal probe, which offers a type of feedback to tell the woman if they're able to contract their pelvic floor muscle effectively or not. And so that will give them some information to be able to share back with Alison's team. So what Alison said here is supervised self-assessment is not an alternative to face-to-face. However, in difficult circumstances that we're facing, is that it's an option to use in the short term. What we've got to consider is what if it becomes longer term? How do we deal with this then? So of course, it's a shifting sands all the time. And I think we have to be mindful. And of course, we're all going to be sharing from each other. So what I do, you may benefit from, and what you do, I may benefit from you. So it's really about sharing practice. I just wanted to tell you about the case study that I was involved in. And it's a very different type of case study. And this is around provision of product for a particular group of people who had to come out of hospital quite rapidly to free up beds for people with COVID to go in. And this was in the first lockdown. So the standard process is patients undergo a clinical assessment if necessary, and an appropriate product is prescribed. And I have amazing colleagues out in the community in Cornwall who will do their clinical assessments and also provide that product if clinically required. Patients are supported by those community nurse teams and or care visits, and care allocation may be up to 2 carers per visit. In Cornwall, we tend to promote the 2-piece system. So that's our go-to. We have a standard formulary, and we try to encourage our patients to work with a 2-piece. We do have exceptions for the slip product and the pant product for different cohorts of patients. However, this particular case study took us into a new type of product area that we haven't really worked with for a while. So what we wanted to do in this case study is relieve pressure on the acute services. So the clinical commissioning group contacted me and some other people and said, how can we develop a good end-of-life care box for patients coming into the community back to the care of their families and loved ones that will not necessarily have input from the professionals, because it was of social isolation, social distancing, and the challenges of providing care and keeping people safe. And this would be people coming home rather than going to a hospice or hospital beds. And of course, the challenge is that some of the carers for people coming home in this end of life situation could be older or frail, and professionals weren't able to complete the assessment process as we would like to do. And so there weren't professional carers involved, and sometimes there was only one carer available. So in collaboration with the clinical commissioning group, my community nurse colleagues, and other people as well in the multidisciplinary team, we said, what is vital in a product to be able to maintain dignity and comfort? What is going to be easy to use and we know will do the job? So with Essity's support, and very rapidly, these boxes were set up with lots of things in there, but what we contributed in my service and through Essity, paid for out of a central budget, and that was a COVID budget, was the Tenor Flex. Now, the Tenor Flex is something we don't use in Cornwall except for very, very few cases. But this was a really good opportunity because the product did the job for what we wanted. And as we can see from this slide, if we take each of those challenges, on the right-hand side, you can see what the product, the Tenor Flex, offered in terms of meeting some of those challenges. So I think that was a really good example whereby hearts and minds made things happen. We know that we can, if we got the hearts and minds, we can change things, we can make things better. So we got rid of all the red tape as best we can because we knew we had to do this. So this collaboration was really, really rich and vital. And I have to say thank you to Esty, because we were on the emails daily and it happened really quickly. And so the best ways of managing this particular situation were considered by the CCG in a very patient-centered way. Rather than focusing on product cost, we thought, what is best here? Let's put cost to one side, and we know we're all challenged by cost pressures. The considerations are, do we need to reframe product choice now that the COVID situation seems here to stay, with or without vaccine? And is the end-of-life experience any different to the experience of other patients discharged from hospitals? So it does raise some ethical issues and some questions, and I think this is our constant journey of learning. So in conclusion, performing a gold standard CONS assessment may not be achievable in the current climate, but what we can do is still strive to do the best we can, learn from each other, take care of each other. And of course, we often talk about resilience, but it really is important. So we've got to stay and keep doing the good work. And our services, Continence care services, we've got to make a voice for them, make a voice so that actually we remain heard and we don't get lost in everything else going on, because our patients will need us for now and always. And context problems are devastating to an individual and their family. So there are ways that we can adapt procedures to enable assessment, as Alison has shown us in her work and what we've done in Cornwall. So there are many new ways of working, and now we can embrace that. And I just want to say again, thank you to Essity. And here, there's some information about the Flex. We use this Flex in this particular case scenario, but they have a wealth of information. And now Essity are providing us with virtual packs so that we can share with our residential home colleagues and also our community and nurse colleagues. So thank you very much for listening, and I'm going to hand you back to Claire.
Thank you, Sharon. That was absolutely brilliant and fascinating insight into the way that you're working at the moment in the current climate. We're now going to move on to the question and answer session. Remember, you can still take part at any time by commenting on the video. And so we're going to move on to our first question. So question 1 is from Anna. Which of the new strategies that your service has adopted in the current climate do you think will stay post-COVID?
Thank you for that question. I think definitely it's going to be telephone consultations. So what we'll probably do is have a different process for adult patients or adult referrals that we triage. So what we may do is all patients who are triaged to my service, we will telephone, and then out of those telephone consultations will emerge those patients who need a face-to-face. So I think that's really, really useful. And so therefore we will avoid all of that backlog that we did have, the huge waiting lists because we didn't have enough clinic rooms. So what we can do now is make sure that we can focus our clinic rooms, and so we can funnel all of the patients we telephone and funnel them into a face-to-face clinic rather than seeing everyone face-to-face. And we were always thinking, we're always working on the back foot, which clinic room is available for us. So now we can actually be a little bit more, well, smarter. And I think that's definitely something we'll take forward.
Okay, thank you, brilliant. Next question is from Ellie. Can you give more information as to why your service is continuing to do face-to-face assessments for children?
Yes, I have a children's nurse and I'm very blessed to have her. And we talked about this and we said, if we do telephone consultations, should we do that for our children and young people as well? And we agreed not to. So what we believe to be right for our children and young people is offer them a face-to-face on the first. So they will all be offered because of the safeguarding concerns. And we want to be able to have those cues. It doesn't take away from the fact that we know that elder people can experience abuse as well. But in terms of our children, we would like to see them face to face with their parent. We can get so much, and it's really important to speak to that child, because sometimes the child is at school or the young person's out at college. And so sometimes we miss the interaction with those younger people. So face-to-face with the parent and family and the child, young person, is really important. So that's what we're going to stay face-to-face with them.
Okay.
Back to clinics.
Okay, question 3 is from Sarah. Do you think there is scope to streamline or simplify the assessment process and paperwork to accommodate this new climate, as often paperwork is incomplete?
Yeah, I think you're right. And I think we're challenged across the country because we've never had one style of assessment form. And I think if we talk about all services across the country, we're always doing something slightly different. We use in Cornwall a self-assessment process, which means that the patient tends to, and including our children and young people, they will complete data information before they come to us or have a telephone consultation. But I think it's right. I do think there is some streamlining. However, I think I love assessment processes, and I've done my nurse practitioner course on assessment approaches, and I think it's down to the skill of building the rapport and good questioning, good history taking. And I think what we have to do is avoid being pulled off tangent and have the skill to keep the person focused on what we want to discuss. So I think assessment tools are really important. It'd be great to have a countrywide one, or certainly a UK one. And I know that Wendy Colley's work is helping towards that. But there may be some opportunity for streamlining, but I think it's still work to be completed.
Okay, thank you. Question 4 is from Karen. How do we reach a shared bowel and bladder plan of care between care providers to avoid duplication of work and prevent repetition questioning for the patient?
Is this, sorry, can I just check the first part of the question? Health and social carers, was that in the question?
How do we reach a shared bowel and bladder plan of care between care providers to avoid duplication of work and prevent repetitive
Yes, I
questioning
agree.
for the patient?
Yes, I agree. And I think a lot of services would say the same thing. So one patient may be answering the same set of questions for, from a physiotherapist, an OT, a speech and language therapist, a clinical nurse specialist, a community nurse. So I think it is a challenge. We are on the road, many areas, to integration. So I think integration is possibly a platform in which we can say, let's pull this together. Let's actually make sure that we've got the electronic systems in place, we've got the clinical assessment tools, and we're all following one type of clinical and referral pathway. So I think, again, as I was saying, if there are hearts and minds, I think we can make it happen. But of course, whilst we're working in silos, as it can be called, it makes it difficult. But I think with the integration modeling, and we can do integration in different ways. There's different models of integration. So for example, I would say that I'm integrated with the Urogyne team, with our secondary care. And so therefore we do make sure that there's consistency in what we do and that good communication. But I think there's a lot of work to be done on actually avoiding duplication.
Okay, thank you. Question 5 is from Pauline. Catheter-associated urinary tract infection is well documented, but what is the prevalence of UTI without catheters?
Well, it's probably, I don't know off the top of my head, it's a very good question, but I know it's extremely, extremely high. When I did a study, a tabletop study of looking at people going into hospital with a urinary tract infection who are admitted, there's about 2,000 people per year going in for an acute episode of UTI. And that's not including the people who experience recurrent UTI in females and the UTIs that occur in men. And of course, those occur in children. I think UTI is a very challenging clinical entity to diagnose. We know it's one of the most common things that can present in primary care, but there are different cohorts that need different approaches and probably have different prevalence rates. So certainly from the acute work I did, I knew there was about a couple of thousand people going in. And when we looked at if we could keep people out of hospital, we were able to achieve that by putting in place a remote monitoring service. So I don't think that answers the question very well, but because I think UTI is a really challenging area and different cohorts will experience different approaches to care and treatment and different risk factors.
Okay, I've got a great question from Beth now. How would you explain pelvic floor exercises virtually?
Yeah, very interesting, very interesting. And I think this is where our physiotherapy colleagues can come in. So, of course, there are lots of online tools. And if you're a member of IUGA, the International Urogynecology Association, that's got some really great information on pelvic floor, as does Eric for teenagers. So there's lots of information on there. So it may be working through that with people, but of course it may be modeling using a model. If you're doing virtual, so attend anywhere, which we use sometimes, and actually understanding how people learn. So how does your particular patient learn? What type of language will work with them? So I think there's not one size that fits all, but I would adapt my teaching according to the patient I'm working with. Some may want a leaflet, although we know that's not ideal because we'd want to do face-to-face and demonstrate it through digital examination. So I would consider my particular patient's needs and adapt the language, adapt the information I give, and go through that with them and seek to understand their understanding and see what they can then put into practice. What's important is review and follow-up, because to make sure that they grasped it. And there's lots of little anecdotes like sitting on imagine there's a piece of string that you're sitting on or a coin, etc. So there's lots of little anecdotes that one can use, but I think getting the information right and sourcing the right information that's validated and clinically supported, and also understanding our patients' learning needs, learning style.
Okay, the next question is from Erica. Is there a connection between sleep apnea and nighttime urinary frequency, please?
There can be. So, for example, sleep apnea can change the pressure within the chest, and there is a particular protein that may be released that actually it alerts the body to create more urine. So it creates a diuresis. So therefore, some people then need to have more voids at night, so their nocturia can increase. So sleep apnea can be a backstory to some nocturia presentations. So yes, there is a link. There is a link. And of course, there's lots of interesting articles out there that you can source from the International Concert Society, etc., to understand that. But there is this link, and I would definitely ask my patients if they're experiencing nocturia, and I was able to glean that information from bladder diaries, is what is their sleep pattern? If they sleep with a partner, do they know that they snore, or do they find that they actually stop breathing for a little while? So there's lots of little things we can ask. So yes, I'm always on the alert for that. And it might be we need to encourage sleep studies or referral on to have tests.
Okay. The next question is from John. Are there any elements of your role or your team's role which have expanded or changed during COVID?
Well, it's more, I would say, as a good question, it's business as usual. I think that's the bottom line, it's business as usual. What I find is that we're having to react. We're having to react more as well as being proactive. So proaction is to build the service, be strategic, but stay true to our patient. And so, for example, educational needs, finding ways of providing care and training for hotels that are set up in the community at short notice. How can we as a service provide that? So I think what we're doing is we're being pulled in quite quickly to help make decisions. And I find, the other thing is is that emails are becoming much more prevalent from our parents, families, and our patients. Email is another great way of being able to keep that communication going. So in terms of have things really changed for us, I think we're having to be more reactive, and I think what's important, we have to be flexible. We have to be so flexible. So in other words, I have to sort of probably juggle many things, spin many plates like everybody else is doing. So flexibility with that resilience, looking after each other, but staying true to what I believe in terms of what our service is here to do.
Okay, thank you. The next question. The recent Ofsted report has suggested that some preschool children have gone backwards in some basic skills, including toileting. What impact do you see this having on your services?
Well, what I've noticed is that since September is that we've had more calls from parents and school teachers and Senko to be able to get involved in children who haven't achieved toilet training or their soiling's got worse. So I've noticed a rise in that. Now, some of us will notice that every year. So in other words, when children start a new school or a new class, it might be that the parents think, well, actually, it should sort itself, should sort it out, and of course it doesn't. And so therefore we get an influx of calls around June, July, trying to get ready for the new school term. So I think probably the biggest impact is going to be on our health visitor colleagues and our school nursing colleagues, and they're out there doing a vital job. And so I think it will be supporting each other. So we have noticed an increase, but not necessarily directly related to the Ofsted finding, but this is about children who have probably just trundled along and then gone to school. It's upset the balance. They've been in lockdown for so long, off school for so long, it's tipped the balance, and therefore soiling has emerged or got worse. So we're finding these cases coming forward. What's important is that we're really on the button so we can actually help these parents quickly and swiftly. And we're getting lots more calls to go into team meetings, etc.
Okay, we're having some amazing questions. So here's the next one. This one's from Sarah. How do you define an appropriately trained professional with regards to undertaking a full continence assessment?
Well, I would say, I think the principle here, the baseline, is that a registered nurse is really critical. And I don't have any concerns about a support worker, non-registered worker to be able to do some of the assessment journey, but I strongly believe that a registered nurse is really important in terms of being able to interpret the data and to be able to make some sense of that and come up with a working diagnosis. Education and training is critical. And with everything going on, it might get missed that we lose the momentum for our own education and training. And so that's why SAT have supported us with these virtual packs. It's another opportunity to keep the momentum going for education and training. So we do, in our county, we do a monthly educational session on clinical skills for assessment. That's now by virtual, so we don't do it face to face, we do it virtually, but education and training is really important for hospital nurses, community nurses, wherever they're working. I truly believe that good continence care is everyone's business in the NHS and beyond. So I don't think anyone should not have the opportunity to even know the fundamentals to say, I will ask my patient when they turn up in my hospital or my setting, I will ask, are you bothered by your bladder and bowel? So if there's nothing more, they can just ask that key question and then make sure we do something with it. Because unfortunately, too many people believe that incontinence, for example, is inevitable, and it's not. It's not normal, and we need to do something about it. So education, training, support, different modes of doing that as well.
Okay. The next question is from Jane. There are more people living with dementia where compliance is an issue due to poor cognition, where assessment and management is very difficult. Are there any tools or information available for care home staff to use to support these patients?
I think that's a difficult one. I do think I pulled from the Alzheimer's Association and Dementia Societies some of the common conservative measures we can use. I think it's challenging. There are no two ways about it. It's very challenging. And I think the critical thing is, how do you tease out if there's a physical problem when actually the individual may have lost their skill of continence? So it's how to tease that out. And I don't think it's easy. So I think whoever's involved with those patients, those individuals, really need to seek help. And so what I would hope is that people working in settings where they have people with a cognitive impairment, that they actually seek learning, seek education, and come to, for example, in my county, to come to my team and say, how can we help? How can we help this individual? And so in terms of environmental factors, good signposting, good use of toilet seat covers in terms of colouring, etc. Regular toilet visits, but based on their own individual patterns. There are some common approaches, prompted voiding. There's lots of toileting assistant measures that exist. What's important, I think we've got the information, it's about embedding it in practice. And I think that's one of our key challenges when we're all off doing our different things, and it's about embedding that into practice. But I do think we could do with more education on this area.
And that brings us beautifully onto our final question, which is all about education and learning. So it's hard to find continence courses at the moment. Can you recommend any?
Well, that's a very good question, because we run one in Cornwall and the Isles of Scilly and for Devon as well. And we have a level 6 course, 40 credits. What's challenging for us, and I know that there will be other areas across the country who have some education training, we have difficulty is that how are we going to deliver it? Because we've always delivered it with people coming to us in Cornwall to be able to sit in the classroom, and we've had a really vibrant class over 3 months. But of course we have to do it differently. But I have to signpost people to the excellent resources through the Association for Continence Advice. They have the MOOC training, which is brilliant. So there are lots of different things out there that people can do online. However, my course, for example, is challenged because I can't deliver it the way I used to. So I have to really think out the box how I'm going to do that. And it's not easy because we haven't got the resources to develop distance learning. I've got people who want to come from different parts of the country, but they're not going to come down to me in this time of the pandemic. So it's how do I flex myself and my course with the support of my excellent colleagues to meet the needs now. But there are online courses that are available, and certainly through Health Education in England, as well as the Association for Continence Advice. And I'm sure there's many out there as well that I haven't mentioned.
Fantastic. Thank you so much, Sharon. It's been absolutely fascinating. We are now concluding our live training session, and thank you for engaging everyone, and thank you ST for supporting this event. To contact ST, you can email them on hcmarketing@sat.com, and these details will also be pinned in the comment section. The certificate link is now on screen, or it'll be pinned in the comments section. And you can like the UCCT Facebook page to hear more about future events. So that just leaves me to say, take care, everyone, and we hope to see you all again soon. Thank you very much.
Thank you, everyone. Thank you. Thank you, Claire.